Shutterstock Music.
Good morning, friends. It's indeed really a great pleasure, especially, personally for me, to introduce Dr. Pankaj Desai. I am going to split that into two parts. One is a formal and one is an informal. He is a consultant OBGY specialist at Janani Maternity Hospital, Vadodara, former Dean, Students Association, Professor and Head of the Unit of Medical College, Vadodara, gold medals awarded in OBGYN, 61 orations to his credit, innumerable guest lectures, moderator, panelist, and similar academic honors, 107 publications, 13 books authored, contributions of chapters in different textbooks, and so many. The informal part is, every day he can give one pearl of wisdom. Just today morning he said, you should always walk on the right side in life. See, actually, Vadodara is known for the Maharashtrians for one thing, that is Sayajirao Gaikwad. And to all the gynecologists and practitioners for Dr. Pankaj Desai. He has a fantastic sense of humor. I am his Facebook friend, and on many occasions we also exchange few things on Facebook, even on WhatsApp. His politeness or humbleness is just evident when he escorted the teachers today. See, he has a phenomenal memory that he remembered the date of Shirodkar oration which he delivered here in 2003. He is a friend to many and philosophers to all. I request Dr. Pankaj sir to deliver his speech.
कमी नका करू हां असं जाऊ दे थँक्यू हे नको हे मला I will start as usual with a prayer. As wind carries our prayers for earth and all life, may respect and love light our way. May our hearts be filled with compassion for others and ourselves. May peace increase on earth, and may it begin with me. Honorable President of Sholapur Society, and through him, all the leaders of this organization, Honorable Secretary Dr. Meena ma'am, and through her, all the incoming leaders of this organization. Honorable Dr. Bahubali sir, and through him, all members of this organization. And by protocol, this is a constituent organization of FOXY. So, Honorable past President of FOXY, Dr. P.K. Shah, and friends. This lecture will not end now after 40 minutes, 30 minutes. You can contact me 24/7, and there are at least 4 people in Sholapur who continuously are in touch with me, not only related to sweet nothings, but also about their personal problems in their practice and so many other things. So I will be bringing this again and again during the presentation, and so you can copy it down, and my website is there. You can contact me. I will 100% reply. 100%. But when I will reply, I don't know, but I will 100% reply. That is a teacher's promise. I was specifically asked by Dr. Virkar sir that, sir, we want nuances in LSCS. And he modified it, and I took it from there. Nuances in LSCS sailing through challenges. These nuances will happen only once in life. What will happen every day have already been taught to us for years together and decades together in medical college. For that, you don't come to a CME. In CME, you come to have additional package, extra package. When one of my car's insurance was to be renewed last week, my wife told me that, please see that what extra they are giving. Because routine we have already insured. So what extra? And this is not the main lecture, but I'll take 5 to 6 slides for something which is bugging many practitioners, and therefore just sensitizing you to that as a teacher. And that is the challenge of invasive placenta, which is a nuance for us now comparatively. In my entire residency and in my entire assistant professorship and professorship, I have seen hardly one case. But now the situation is completely different because increased incidence of caesarean section. Whatever be the reason, it's okay. We don't want to criticize, and we don't want to become judgmental. Fine, it is saving millions of lives, and anything good. Bahubali sir will bear with me that when we were young, we had a song in film Kajal, "Achho ko bura sabit karna duniya ki purani aadat hai." So let us not criticize caesarean section and join that bandwagon. But there is a good news. And what is that good news? That ultrasonography is sensitive enough and specific enough for the diagnosis of placenta accreta. If you are not doing all ultrasounds yourself, then whenever you send one for an opinion, which I do, or if you are doing all, I send only one for a 20-week scan, so that I don't miss any of the malformations and whatever we do at 20 weeks. Specifically ask for, and you can look for it also. Teachers like Dr. P.K. Shah have taught us, and Dr. M. Rawal, his teacher, about ultrasound. And this is what we have to see, this gap. If it is there, relax. Specifically, your eyes will see what your mind knows. The interface between the bladder and the uterus is usually fairly thick and clearly identified. If you find that there are gaps like this, if this is, then please ask for an opinion or label it as invasive placenta, and you know how dangerous it is, and still not be afraid of it. Medical legal people have made us extremely fearful for one case which might happen in the entire life. We shudder 24/7. So don't be afraid, but handle it professionally. This is last week's ultrasound in my hospital. This is a normal finding. Don't start jumping just because you see a vascularity. You can see here, actually it is the cervix, and here is the lower segment. This vascularity is very much above, and this is a normal finding in early pregnancy. It can be there, so don't start jumping also discount between the two. I'll finish it here and then come to this main lecture. Be aware of it. Specifically look for it or request your sonologist. Specifically now, in cases of previous scissor, please commit or rule out invasive placenta. Bas, that will be enough. Now we come to situations we'll get once in life. They are all true to life situations as happened throughout the world, somewhere or the other. Most of them in India. I will tell you the source also from where they have come. And I will require a microphone and I might ask you to tell as to how you will handle. Can I get a mic, please? Will you help, please? मी तुम्हाला सांगेल मध्ये फिरायला लागेल तुम्हाला. Okay. These are not run of the mill cases. No. For that you don't require me to travel. Started yesterday morning at 5 o'clock. My driver picked me up and dropped me at the airport to come here and give a lecture today at 11 o'clock. Run of the mill, everybody knows. But something new, and see this. A 37 years old G3P2 was admitted with 36 weeks gestation, obstetric history, first full-term normal delivery, second LSCS for placenta previa. Are you with me? I am going to ask you questions so that you don't go to sleep. Of course, I will not ask PK Shah or Bahubali sir or Sir Desai madam or madam there, because they have taught me. Okay, here we can exchange ideas. She had multiple cardiac surgeries. And was on therapeutic dose of heparin. Taken up for emergency caesarean section, this time for abruption. Okay? Markedly thinned out ecchymotic and friable scar of previous caesarean section, repaired in 2 layers, tubal ligation done, anticoagulation treatment was resumed appropriately, and post-operative period was uneventful. Okay, has the soup warmed you enough? Yes, ma'am, we'll ask you. That with beautiful pink colored dress. Yeah? Yeah, we will ask you. Yeah? Mike, तिथे घेऊन जाईल? मॅडमला देईल का? Please. आराम से, keep sitting. This is getting recorded and it will come on YouTube channel next week, and I will give you an SMS also as soon as it comes. Is this fine, ma'am? Yes. Yeah? Okay. After 3 months, she comes to the OPD. She presents with recurrent periodic spotting and bleeding. She was on warfarin, but her coagulation parameters were not much affected. So that is not the cause. That is the easier one. But I would not have brought it here if that was the easy one was acting. Everybody knows. There was no chorionic tissue on ultrasound, because you will start thinking of a molar insult or something. No. Endometrium showed a thin strip. Normal beta HCG. What is happening and what would you have done, ma'am? Please. आपके पास mic है, बैठे बैठे कहिए. She has walked into your OPD. We will take 1 case or 2 cases and finish as soon as the time is over. That is my promise to you. We will not go much. Yes, please. Ma'am, what would you do? Such a case, we did a cesarean section, TL done, bad scissor, and now she is coming after 3 months with continuous bleeding per vagina. And ultrasound normal, apparently normal. Any ideas? What you would have done? We are not there. There we have to decide in your consulting. Would you like to give her some hormones? Yeah? Yes? Somebody said yes. Okay. Okay. Medical management was done. She was put on progesterone along with oral iron therapy. She returned after 6 months postpartum for continuous bleeding PV. On examination, bulky, firm, lower uterine mass on clinical examination, felt adjoining the uterus, and on color Doppler, no vascularity. I will show you the picture. This is the mass. Yes. And this is the cervical canal. This is the mass here. Okay, I'm giving you one more picture. Lower dimensions of the heterogeneous mass, it is quite big mass. But there is no vascularity, so don't start jumping about malignancy and this and that. No, it is rare, but something has happened. Okay, मैडम जवाब दीजिएगा, मैं इंतजार कर रहा हूं. As an obstetrician and a teacher, we are very patient people. Okay, a presumptive diagnosis of a poorly healed lower uterine segment with inadequate drainage was made. This is got formed that way. Okay. In view of our multiple comorbidities, including hepatitis C, being on interferon, ribavirin, and therapeutic anticoagulation, the patient refusing any operative procedure and further waiting was now dangerous. What is to be done? Madam, what would you have done? Think out of the box. I will come there and pick up the mic and I will request the projectionist to come here and change the slides. तुम्ही येल का इथे कोणी एका प्लीज तुम्ही प्रोजेक्शनचा कंट्रोल घ्या मी माइक मध्ये बोलतो या स्लाइड करेल तुम्ही चेंज या स्लाइड चेंजर देईल हो what do you think it is not difficult काय करू आपण think out of the box Okay, no problem. I have no reasons to embarrass you. Dada, change karel ka? Basa. Okay. She received monthly administration of intramuscular GnRH analogs, 3.75 milligrams for a period of 6 months. Okay. Next slide. No, previous. Next. 2 months later, she had an acute episode of lower abdominal pain and passage of a large amount of altered blood expulsion from the collection. Okay, are you with me?
Yes.
Yeah? It's a little tough, yes, no problem. I would not have brought it here. Just keep sitting. Can we have the next slide, please? On follow-up, next slide. Her platelet count was 1,02,000, comfortable. INR 2.3. She was on what? Menstrual bleeding stopped. Whatever she called menstrual bleeding or spotting per vagina. And I'm bringing the ultrasound. Wait, what do you expect on the ultrasound picture now? With this picture?
Maybe the mass has reduced in...
Yeah, resolving. Can you have the next slide, please? Here you can see, 1 month later, normal appearing endometrial cavity and persistence of a heterogeneous mass, lower segment mass. You can see the endometrial cavity here. Yes. Here. And the mass is there, but seems to have become a little silent. Her normal menstrual periods resumed 2 months after stopping GnRH. And USG picture was this. You can see here. Transvaginal USG 2 months after completion of, notice the absence of lower segment mass. You can see here it has resumed. And normal looking endometrium. Okay? Little thinking out of the box. No surgery was required. And now what is the picture? The patient has now no gynec complaints. 4 years later, after her last cesarean delivery, post-GnRH analog-induced amenorrhea stopped constant irritation of the uterine scar adhesions and promoted healing. So think a little out of the box and you'll get a solution. Yeah? This case came to me from US, New York, but this lady, many of us have heard her, Lakshmi Bai, and she had reported this case in a very reputed journal. Here cesarean section happened long ago. Next case. And see what happened. A 30 years young subject came to the emergency department with acute abdominal pain, nausea and therapy-resistant vomiting for 12 hours. She had a history of caesarean section performed 2 years earlier. 2 years before she had a caesarean section. Okay? Shall we go ahead? Ma'am, I am going to target you. Can we go ahead? Yeah? हाँ स्टूडेंट है तो क्या है हम भी स्टूडेंट हैं I was writing down notes in the previous 2 lectures. See, a student is selfish, a teacher is unselfish because the student only collects, teacher collects and gives. Okay, so we will see now. She was afebrile and her physical examination revealed generalized abdominal distension and tenderness with tympanic bowel sounds. Something with the intestines?
Adhesions or something?
Adhesions. Okay, excellent, excellent, excellent. We will go further. Okay, laboratory investigations were done as usual. WBC count of 9260, hemoglobin 11.9. She had no comorbidity. Clinically, what do you think has happened? You already answered, there are some adhesions. Yeah? Fine. Let us see ahead. They did an imaging. Okay? You will ask for an ultrasound now? Yeah. Okay. USG abdomen pelvis showed free fluid with probably a hydrosalpinx that had undergone a torsion. Should we explore or ask for further investigations?
Laparoscopy.
So we directly intervene. They did not directly intervene. They asked for a further, they got an MRI done. A contrast CT, revealed a marked distension of the stomach and small bowel, multiple air fluid levels up to middle proximal ileum, and there was a transition bowel loop with no appreciable cause of organic obstruction. Okay? So you would have gone inside to handle the hydrosalpinx, not calling the surgeon, and then phone calls would have started. So they investigated. Okay, probably a little more experienced gynecologist. Yeah? And you can see here multiple a collection of fluids here. Left us wondering that what is happening? How after 3 years of surgery? अब ये सब नहीं होना चाहिए ना. After 3 years, nobody thinks of all this. Exploration, laparoscopy or laparotomy with this finding. You can relax. Ma'am, laparoscopy, laparotomy?
Laparotomy.
Laparotomy? Okay. Unluckily, we didn't follow your suggestion. Considering the previous LSCS, we are giving explanation also. And the probable presence of a single adhesion band, you say, yeah? So stick to what you say, don't worry, most of the times you are right. Despite the hyperdistension of the intestinal loops, a laparoscopic approach was, with possible conversion to open surgery, was decided. This is not the picture of that. But this is the usual thing we see so many times. This is my last week's TLH picture, previous cesarean section. And this is what we had expected. ऐसा होगा, पर ऐसा नहीं था. ऐसा नहीं था. On laparoscopic exploration, the pelvic cavity and the uterus and the tubes were normal. After the initial exploration, we identified a mid-ileal gangrene. Okay? This happened to my niece, my cousin, first cousin's daughter. Okay. The mid-ileal gangrene was caused by pelvic adhesions following previous caesarean section, with remarkable distension of small bowel loops. The adhesions were to the previous abdominal scar. So anything can stick. Yeah? No problem. The ileal loop responsible for the obstruction was ischemic and necrotic. An adequate laparoscopic adhesiolysis and laparoscopic resection followed by anastomosis was performed. and post-operatively, she was fine. Our patient had an uncomplicated post-operative course and was discharged on post-operative day 5 in good health. A small query remained in my mind. Was this preventable? Bahubali sir, what do you think? Is this really preventable? If no, why not? And if yes, why? Sir Desai, madam? 3 years after, yes, yes. So nothing is to be done extra. Just this can happen, be prepared for it. Yeah, okay. But it can happen late after 3 years. So once this case was presented in Indore, in Guwahati and Patna, and about 2 months before I got an email from Patna, one of the audience members. She emailed me that, sir, thanks to this case, we got a case now after 3.5 years, and because of this we were aware of it and we could easily manage her and we were not ruffled. Okay, they were not ruffled. So therefore you come to such CMEs to learn new things, maybe rare, it's okay. Now one more unexpected thing. A 25-year-old G2P1 complained of cyclical oozing of blood from her cesarean section scar for 3 months during menses. Okay, yeah, I know. If it was so easy, I would not have brought it here. She had history of LSCS done 9 months back with no past history of any chronic ailment, including tuberculosis. On abdominal examination, 2 pinpoint openings were seen at the scar site. 2 pinpoint openings, not the full scar. Okay. On ultrasonography and CT scan, there was an evidence of fluid collection anterior to the uterus, which communicated with the skin by 2 linear tracts of size 2.6 by this, and another also 2.4 by 9 by 0.36. I'll show you actually the collection and the scar. Please keep watching here, here, and here. Okay, we go further. Fluid was seen coming through the fistulous opening on the skin, and the other end of the opening was seen at the level of isthmus. So hysteroscopy was done. And hysteroscopy showed these openings in communication with the abdomen. Anyone would like to tell what has happened? Fistula. Okay, intracutaneous fistula. Okay, any other input? And sir, why must have that occurred? Because we do thousands of cesarean section. Madam has analyzed 1,700 in her data from January to August. So here, sitting here, if there are 50 people sitting here, 8,500 from January to August. 85,000 cesarean sections. So many. And why it doesn't happen regularly and why must have it happened here? Any ideas? Anyone can give an input? What do you feel about this? Suture material did not get absorbed, even though Vicryl was used. It can happen. Fine, thank you, madam. Uterus was densely adherent to the anterior abdominal. I will show you the laparoscopic picture also. Now what? See this. This is the abdominal wall. This is the adhesion. This is the uterus. We all know this. What should we do? Anyone? Dissect. Dissect it free. That's all, and finish it up. Adhesiolysis, that's all. And close both the ends of the fistula. So let us see what they did. Adhesiolysis was done with harmonic and scissors. That's all of us do. The opening of the tracts in the uterus was visualized by passing dilators. Through the fistula's opening from the skin, and right up to the skin it was excised. The abdominal LSCS scar with fistulous tract, that entire thing was excised. Not only that closing of the openings, because the problem is deep inside. It is not those 2 points is where you see the fluid. Poor healing is always around. We know this. Okay. The abdominal LSCS scar with fistulous tract were excised and sent for histopathology examination. This was the picture. You can see here from the abdomen, skin, and this going inside, and this whole thing was excised and resutured. Remaining defect was resutured. Was it good to send to histopathology? Yeah? You expect something? Arey wah! Salute Sholapur. Therefore, Baroda adopted your name for even our Chivda, Sholapuri Chivda. Okay, Baroda is famous for that. Histopathology of the sinus tract was suggestive of tuberculosis. Patient was started on anti-tuberculous treatment and post-operative wound healed without any complications. Credits to, I have his permission to present, I rang him up. Dr. N. Shah from Mumbai, from Vardhan Multi-Speciality Hospital, and had some additional features also asked him on phone. The next was the price you pay to be a senior. And what was it? She was in her third pregnancy with previous 2 LSCS. This patient, which we are going to discuss. The obstetrician was sure that she will go in for one more pregnancy as the gender of the child were not of the liking of hers as well as her family. Fine. Not discussing all those. Daya baini, dai vato, leave it outside. She was told, go to a senior doctor next time, don't come to us. I will say, go to Sir Desai madam or Bahubali sir, don't come to us. And so she came to me. I studied the operative notes that was also given along with it, and quite a detailed notes. It stated that there were dense adhesions between the lower segment and the bladder, and only with great difficulty could they access the lower segment. Already, in the previous Caesar, one Caesar only, her healing system was such that it overreacted. Okay, as we saw this morning, regarding the free iron which gets released, in some it was the labile iron. The explanation was given was that this is immunological response. So how it responds, we don't know. But in her, it responded in this way. Less how many previous cesarean sections, even previous 2 cesarean sections, nowadays we take them up for TLH. Okay, we see adhesions, but this was too much. They were not able to access the pelvis. So what choices I had before me, I'll discuss with you and then come to another alternative. I discussed with my wife and we decided that either we do a classical cesarean section and a concurrent sterilization, or try dissecting the bladder patiently and be prepared for both hemorrhage and bladder injury. Okay. You agree with me? These were the choices which I thought at that moment. But usually your best thoughts come when you are under a shower, and that is where, sir, you rang me up to this morning, or when you are in the gym. There is science behind it, that your synapses which are firing at the same frequency, they break in gym when you are exercising. And therefore, new ideas come in. Madam, you are a practitioner of yoga, you teach yoga, you know this. The new synapses form and therefore new ideas come. And I got this idea while I was in the gym, and I thought, why not do a cystoinflation? Normally you want the bladder to drain. Nowadays we don't catheterize. For last 25 years normally we don't catheterize previous cesareans, even any cesarean section. But here you catheterize it, distend the bladder with 200 ml of nanosaline, tie up the catheter so that you can see the enemy. Okay, this is its extent. This is what I thought. Do you agree? Will it help me identifying the bladder? Sir? Yeah? Is this a good decision? I am entering, that what was the word used? A surgical strike? Okay, वो जो रात को ही होती है. Okay, this is what I did, discussed it with the team, and I sought support from data. My thinking, your thinking doesn't matter. I want data. Now, Hans Rosling in his book, Factfulness tells, one of the finest books I have ever read. that in case of doubt, fall back upon data. What does data say? Not because I said so. Who am I? Look at the data. And I searched for the data. Thankfully, she was not yet at the point of cesarean section. I got enough time to do research. And I found a good reference. And that reference was just 2020. They conducted a prospective randomized controls trial to find out whether improved identification of bladder margins by cystoinflation could decrease bladder injury rate and blood loss without causing urological complications. Okay, let us see what they found. Because madam was giving us data regarding the or preload and co-load. I was looking at it very intently, madam. And when Dr. Pikesha was giving us data regarding iron increase and all, I was looking at very intently. We looked at the data very intently, and being a teacher in medical college, we are used to seeing data and analyzing data. This study included 214 healthy women with previous operative deliveries undergoing elective cesarean section and found to have dense pelvic adhesions. In this study, cystoinflation was very effective to significantly reduce bladder injury rate and blood loss. But bladder apna dost hai. Don't be afraid of it. We did it following this data, and I could dissect through. Of course, cesarean section, Dr. Pikesha being in government all throughout life will tell that you should not do a concurrent tube ligation. We handled it in our way. But then important is, yes, cystoinflation can help you in certain very important situations. Will I exactly identify where the bladder is? It will come in the way. No, bladder is a very kind wife. It shifts. If you tell shift, it will shift. It is not a girlfriend who will fight back. Okay, endometriosis is like a girlfriend. It will fight back. It will bleed. Bladder is, it is soft. It shifts. Okay. The last case. Sir, do I have the time for the last case? Yeah? Okay. I have gone to 33 minutes. Last case. Okay. Mrs. S, aged 34 years, G2P1, with amenorrhea 38 weeks. She had history of previous cesarean section for non-progressive labor. She carried no papers of previous obstetric performance. कोई कागज नहीं है साहब. क्या करोगे आप? Give her lectures, break your head, nothing. Okay, chalo. On examination review, she was found to be fit for vaginal trial, so she was admitted for induction of labor. All other prerequisites you know, we will not go into details. Just on the day prior to the planned delivery, in fact at night, she came to labor room with something coming out per urethra since 4 to 5 hours and severe pain and difficulty in urination. What it must be? Any idea? You get this phone call. Thankfully, I live in the same premise. So you get on the intercom, the nurse tells, Madam, to my wife, we are both gynecologists, Madam, पिशाबची जागावून काहीतरी येते बाहेर आणि फार दुखते असं म्हणते. What do you think? Bladder prolapse? Huh? Loudly. Calculi. Okay, let us see. Pelvic examination revealed closed and uneffaced cervix, but a bag of membranes was bulging through the urethra, which could be reduced by pushing it into the urethra or by keeping the patient in Trendelenburg position. I will show you the photograph. Gappe nahi marta mein, no fairy tale. You can see it here. Case happens once in life, but once we are aware of it, I am not making you afraid of it. Fearlessness is in my DNA. Never afraid of anything. Here it comes, except my wife. But then, and that also out of love. But then, ऐसा बोलना पड़ता है ना sir? Okay. This is the picture. Don't be afraid, but you are aware कि हाँ एक किसी को हुआ था ऐसा. Okay. What has happened? Anyone would like to tell me what has happened? Ruptured uterus? Okay, let us see what has happened. Sonography showed a singleton pregnancy of 37 weeks gestation with adequate liquor. कोई बात नहीं, no problem. We go ahead. A fistula was indeed noticed between the anterior wall of lower uterine segment and the posterior wall of the bladder. That must be a weak area. We identified ultrasound early days. I remember even Dr. M.Y. Rawal telling us, no, lower segment, there are windows. One of those windows, you should not be afraid if you see windows. Okay, on ultrasound, on lower segment. These are normal finding. But one of that weak point, probably a bag of water was noted to be protruding into the bladder. From there. Okay. How to handle? Anyone would like to tell me how to handle? Madam, don't be worried for a headache. There, madam. Don't be worried for headache. It proves that you have a head. So many times I have to do like this. Hai kya? Hai kya? What do you think? क्या करेंगे आप? आपके क्लिनिक में ही हो गया. क्या करेंगे आप? रात को होता है ये सब. दूसरे दिन पोस्ट किया है, सब अगली रात को ही होता है. क्यों पता नहीं. ये जादू सब क्यों होता है ऐसा? पता नहीं. अगली रात को ही होता है. अगली रात को पेशेंट भाग जाती है. अगली रात को ये ब्लैडर चला आता है. बैग ऑफ वाटर चला आता है. What did you do? You have a wonderful teacher next to you. You will call her.
Sir, open emergency.
Open it up.
Yes, sir.
Open it. Okay. Fine. Classical cesarean opened up. Classical cesarean section was done. You can create a controversy, no problem. With sterilization, with repair of vesico-uterine fistula at the same sitting. At the same sitting. Intraoperatively after the delivery of the fetus and the placenta, a 0.2 centimeters wide vesico-uterine fistula connecting the dome of the bladder to the lower uterine segment was noted. कभी एक बार होगा जिंदगी में, पर आपको याद करा के जाएगा. And it will get discussed in the next clinical meeting somewhere and someone will be benefited. The entire fistulous tract was dissected open, separated, and both the openings were repaired. As was the thinking at that time, omentum was tucked in to cover the raw area, continuous bladder drainage for 21 days, and she was relieved of the problem. This case came to us from Jaipur, and this is how it was handled. So friends, caesarean section can leave long shadows. You have seen after years. And that is where you have to be a very efficient obstetrician and an efficient manager, very alert of what is happening, very in full command of what is happening, well informed, well read, and well informed by attending sessions like this. Then your dedication and commitment will 100% make you feel, and even the patient will tell, well handled. Few days before, got a phone call from one of my juniors. Sir, the patient we did a TLH yesterday was talking with her husband and just gone. Embolism, yes. But then the way we rushed down and the way the team worked, the patient's relatives had tears in their eyes because when I left, I explained as a senior that what has happened. They bowed down to the team. We knew she died, sir. At the moment when she was talking with me, she died. We know. But the way you made an effort, and that is the time, people like me will go out and jump like this, well handled. For that you have to be well informed, well read, and then you can relax to say this. Let our selfless service be our prayers and our meditation. The best way to honor our lives is through serving humanity. There is no better way to honor our lives. No other honors matter. Thank you, ladies and gentlemen. Thank you for Thank you so much.